Dr. Jaiprakash Agrawal, MD Psychiatry, Professor and Head Department of Psychiatry, Gandhi Medical College, Bhopal. So good evening all. Sir, you can proceed session, sir.
So I have to share my slides. No?
एक सचिन चित्तवर डॉक्टर है और एक ये है
Now the slides are visible.
डायबिटीज का डॉक्टर
Are the slides visible now?
Visible,
Visible,
sir,
sir,
visible, completely visible.
Yeah, very good afternoon. Good evening to all of you. Thank you, Dr. JP Agrawal, for joining us. And thank you, Team Lupin, for giving us the opportunity to present it. So I've been given the task to talk about diabetes and its reflection on mental health. This is something I'll be focusing on diabetes, depression, and risk of dementia. This is something a very burning topic. I was just discussing this with Dr. JP Agrawal also. And there are so many guidelines, there are so many new things, but we all know since when I was doing my post graduation, at that point of time, one of my batchmates, now he is basically in US, and he took this topic of diabetes and depression. That was way back in 2001. And I still remember the kind of conclusions he made. That was the involvement of somewhere around about 40% patients of diabetes who had some kind of mental health related problems, and preferably dementia. So there are so many things which are involved in it, and that is something is very important. So unhealthy lifestyle, that is diet in processed sugar, fats, inadequate activity and sleep. Because we people are very busy nowadays, we give prime importance to our careers, and there are so many things which come in between when it comes to lifestyle. The lifestyle is unhealthy because, and when the fruitful years, you are being made to work and see the software professionals, the kind of lifestyle they have, the kind of lifestyle people have in IT industry. That is something very taxing. And this is somehow, somewhere it takes its toll because you are the one who are competing with your colleagues. You are the ones who want to stay in the race, and over the top of it, you are diabetic. So that now you are carrying two burdens. Take care of your sugars also. You want to have lessening of the complications, and over the top of it, you want to perform. And that is something which is there. And there are some other causes like poor resources, low income group, low education, unsafe neighborhood, poor healthy literacy. This is also a problem in people who are from the lower socioeconomic status. And the chronic stress response like cortisol, pro-inflammatory cytokines, as we all know, the counter-regulatory hormones like cortisol, catecholamines, glucagon, they are actually the ones which increases the sugar. That is something, the interplay of all these things actually leads to problems. So let's come to depression and diabetes link. See, the depression and type 2 diabetes, the relative risk is 1.54. Depression is common in diabetes. As I was quoting one of my friends, he quoted somewhere around 40%, it is 10 to 30%, and depression associated with worse biomedical outcome, 2 to 3-fold increase in mortality. And depression is underdetected yet highly treatable. Majority of my patients in clinical practice, they have this problem. Either the way they overreact or the way they are actually reacting in the scenario. In our clinical settings also, there are so many patients who are actually inappropriate in their behavior, and they have got they are very emotionally labile, and some of them they come with emotional kind of thing and impending doom kind of thing. Something has happened, and in future they are worried about the complications. Some of them are worried, ki, why just me? Why I've been made diabetic? I'm very unfortunate. Such kind of things do see in practice. And that is a very big problem. Sometimes we face their outburst also. And that is something where the clinical scenario we face in our clinical practice. And the prevalence of depression is increased in diabetics versus no diabetics. 1 year prevalence of depressive episodes in diabetes was 9.3% as compared to 3.1% 2% without diabetes. The primary care patient sees the data for major depression, other depression, and diabetic population somewhere around about 15 to 30%. And this is a meta-analysis. And 30% versus 15% cause ratio is there. And diabetic women, they are more prone as compared to men. This I was coming because I'm seeing in my clinical practice, 80% of the patients are women. And they are the ones somehow, somewhere, then we are in a state of trouble because they don't want that we should label it as depression. And majority of the time, they come with a notion that they should not get an antidepressant. So this is the scenario. The kind of acceptance, the kind of acceptance for problem, the kind of morbidity we have, and the sensitivity of the person who has come to us for the service is less. So depression is associated with all stages of the diabetes continuum. And see the odds ratio is 1.37 for pre-diabetes, and for diabetes is 2.1 as compared to a normal population, two times more chances of depression. And see the effect size, suboptimal glycemic control, it also affects depression, complications, hazard ratio, and see the hazard ratio for mortality is more. So this is a burning problem which has not been taken care of properly over the years, and especially in India. And the common mechanisms for depression are diabetes specific distress. Just now we have completed 1 hour of us. This is with Dr. JP Agrawal is also there as a co-guide, diabetic distress. And there are also the data is almost similar regarding the depression regarding the biological process. See the hypothalamic axis, definitely this intermilieu of the hormones where they are actually somehow deranged because of the stress, because of the impending doom, because of the problem. And the autonomic nervous system is also impaired in diabetes. Early life programming, antidepressants, circadian clock, gut hormones, and satiety. Sleep apnea is also a major problem because in clinical practice we were not very sensitive. Till date, I don't find physicians very sensitive about sleep apnea. There are so many things. Then the interplay of all these things actually leads to this problem of depression and type 2 diabetes when you search for a common origin. See, for the fetal, it starts on the fetal nutrition, genomics, there's social adversity, lifestyle. There are so many things which gets embedded in your personality. And depression is common in type 2 diabetes, associated with increased mortality. See, the mortality is also going up. And treating depression alone does not improve the glycemic control. So this is something we'll have to take both. We'll have to take care of diabetes, we'll have to take care of depression, and there are so many corrections which are to be required on our behalf. And the responsibility is huge because both depression and diabetes is associated with high risk for all cause dementia. Dear friends, dementia is something which we never thought of. I still remember when our professor was a neurologist and he used to do this World Dementia Day, and I used to compare during his dementia programs. To that particular point of time, we were MDs, and this is I'm talking about 2005. We were not very much aware, and just because of his programs, those appraisal programs, we actually came to know much about dementia. It associated with hazard of all cause dementia, that is 31%, and the long-term hazard ratio rose to 42%. And mechanism suggested behind this is increased inflammation because diabetes is a chronic inflammatory state, decreased insulin sensitivity, autonomic nervous system dysregulation because long-standing uncontrolled diabetes, we know about this. The sweating mechanism is gone, the BP is not well controlled. The moment you stand, there is a postural loss of blood pressure and you tend to fall. Erectile dysfunction. Apart from that, there are so many things. And over the top of it, if there is obesity, obesity is most of the times I say in my presentation nowadays is the next diabetes. It is just a play of words, but definitely the kind of morbidity and the kind of complications we are facing with diabetes, definitely we are going to face it with obesity also. So magnitude of the associations of depression as well as comorbid depression and diabetes with vascular dementia risk was more pronounced. So this is the JAMA psychiatry. And both depression and diabetes is associated with high risk of all-cause dementia. The risk of all-cause dementia among depression alone, diabetes alone, and depression and diabetes, these are the cohorts. And see the data, depression and diabetes, hazard ratio of 2.17. 1.88. So this is something which is even heading towards worse, and we are less sensitive about a problem which as common as diabetes, and that's why this is again, I will say it's a good thing which they have done, because very rarely we talk about the psychiatric problem in diabetes. So dementia affects 6 to 10% of people. 65% year or older rate increases with age. As age, they get more demented, and depression estimated to affect around 1 to 5% of older adults. Depression is common in dementia, 20 to 40%, and it is probably a risk factor for both vascular dementia and Alzheimer's dementia. It's very typical about vascular dementia is the stepladder pattern. If you have a relative, he or she is hypertensive, diabetic, and has got the episodes of transient ischemic attack where there is loss of movement of one half of the body for particular few minutes or hours, and later on it recovers. But that activity goes on. There is a repeated kind of injury to the brain when you have multiple atherosclerotic emboli, and that the patient deteriorates and recovers. That is the step-laden pattern. And later on, at one point of time, the whole intellect is gone. That is the vascular dementia, very typical about that step-ladder pattern. And Alzheimer's dementia is something which has got some hereditary predilection. And we know what people say is if someone is getting demented, he'll be happy throughout his life. But the most unhappiest person will be the one who will be taking care of this demented person. So that is why the morbidity, seen to the morbidity and the kind of old age, the average lifespan is going up. This problem will be a very big problem in coming 15 to 20 years from now. So diabetes and depression exhibit a closely linked bi-directional relationship. 15 to 20% diabetes will develop clinical depression. So depression is 2 or 3 times more common among diabetes compared to without diabetes. And comorbid depression and diabetes have 2.7% increased risk for dementia. So the bidirectional link between depression and diabetes, these are the prospective studies. And they're just talking about, see the forest chart, with the comparative prospective studies of depression and instead type 2 diabetes. And the odds ratio is towards dementia and complication of diabetes. So depression doubled subsequent all-cause dementia risk. So this is again a problem. A history of depression may confer an increased risk for later developing of Alzheimer's disease. This may relate to or reflect an independent risk factor for the disease. An interval between diagnosis of depression and Alzheimer's disease was positively related to increased risk of developing Alzheimer's disease, suggesting that depression may be a risk factor. A meta-analysis evaluation resulted in pooled odds ratio of 2.03. Not getting much into this, the obstacles to recognize depression in medically ill, medical symptoms mask depressive symptoms. This is true. In my clinical practice, what I have is if the sugars are controlled, then also they come with the complaint of कि डॉक्टर बहुत कमजोरी लग रही है, we are feeling low, we are as if I'm feeling completely drained out. Then we go for other investigations. If the hemoglobin is normal, if the sugars are normal, if the blood pressure is also normal, no other problem related to sleep and all, then definitely sometimes when we explore the sleep kind of thing, they say sometimes we are irritated, we don't go to sleep. Sometimes they tell us regarding the hopelessness they have, and that is the subtle depression kind of thing what we see. And definitely Dr. JP Agrawal will throw more light over it because they see full blown cases. So it is very common. And when we add antidepressants to such kind of patients, after ruling out the rest of the things, that is something is an utmost responsibility of a physician. And they recover very fast and they are very happy next time. And so this is something which we should learn. And serious medical illness make depression accepted as a normal reaction. Vague presentation of depression in medical setting. This I was talking about. So this is something which is very common. And in my clinical practice, also I'm facing this. So obstacles to recognize depression in medically ill patient. What are the obstacles we have? Not diagnosed with depression or something. There are so many things. Not diagnosed with depression, high somatization score, diagnosed with depression upon further examination. I think this falls in domain of Dr. K.P. Agarwal. So he'll be covering it nicely. 90% of depressed patients reported primarily somatic symptoms. There are so many somatic symptoms like chest pain, tachycardia, neurological, headache, dizziness. So As a physician, we write antidepressants to good number of our patients, and somehow, somewhere, our colleagues say, "Yeah, you are very irrational with respect to writing antidepressant." But dear friends, this is not true. The morbidity of this problem is definitely there, and we know this in our routine general practice of medicine also. Even if we are not seeing diabetic patients, the majority of the patients, if you will analyze it properly, definitely they will have this component. So the morbidity of the illness is something beyond actually right now the estimation. And I think that JP will throw more light over it. So the pre-morbid depression have 30 to 37 to 100% increases of developing type diabetes. So DM risk independent of obesity, activity level, smoking, alcohol, consumption, and family history of diabetes. Mean age of the onset of depression typically predates the age of onset of type 2 diabetes, and mean age of the onset of type 1 diabetes usually predates the onset of depression. The depression was diabetes morbidity, and see the cold hands and feet, and this is burning of the hands and feet, pain in hands or feet. Majority of our patients who are actually having this neurological symptoms of definitely nowadays the drug preferred is with pregabalin. Nowadays we give nortriptyline also, and that is somehow somewhere is also causing lessening of the neurological pain and also curing the depression. So that is true. That's why in market you get so many combinations of uh, gabapentin with nortriptyline or pregabalin with nortriptyline, or definitely we are giving duloxetine also sometimes. So depression as a contributor to diabetic morbidity and mortality, when it comes to like that, it is the poor glycemic control, less adherent to diet. This is very common because if you will see the data for HbA1c control in our patient, hardly 20% of the patients have HbA1c around 7. So that is the morbidity we have. That is the kind of cohort of population we have. Increased risk of diabetes related complication associated with retinopathy, nephropathy, macrovascular complications. Depression can aggravate that or vice versa. These patients, after getting these complications, knowing the outcome, they get depressed. So these are the two tricky situations we are dealing with. Coronary heart disease is more rapid in depressed women. Depressed, this we know because depression itself is something which is increasing the cardiovascular poor cardiovascular outcome and the lower quality of life. That's very so. When it comes to higher healthcare costs, definitely the morbidity is high, so the cost will be high. Symptom amplification, patients experience more diabetic symptoms, experience when controlling disease severity. Depression may have a worse course among diabetics. Relapse rate is 5 times higher than non-diabetics when not on prophylactic treatment. So depression, worse diabetes mortality, and see this mortality, it goes up like anything, and the risk is quantifiably high, and it should not be ignored. And the downward cycle of depression and diabetes, see the depression will lead to lack of motivation, poor management. But definitely a depressed guy or a lady will definitely not be will be less sensitive with respect to the timing, the precautions, the diet, the exercise, and all. There will be a high inertia with respect to doing these activities, and the high blood sugar levels will again contribute to greater fatigue and lethargy and worsen the mood. And it will again, this is a vicious circle, depression begetting diabetes and diabetes begetting depression. So that is something very interesting and different. Just pay attention to this slide, the glycated hemoglobin and cognitive decline. This is just talking about uh, this is age of the patient was in the study was 56 years, women were 56, 21% were black, and mean HbA1c was 8.5. And diagnosed diabetes was associated with cognitive decline. And let's see the DSST score, odds ratio was 1.42. And but HbA1c was not a significant independent predictor of cognitive decline in the study when stratifying by diabetes diagnosis. So this is something which is there, but still it has got some rules. What can be done to reduce development of dementia in diabetes? Pressure control. As I already say now, there is an era of 360-degree diabetes control. When it comes to 360-degree control of diabetes, you need to take care of blood pressure, you need to take care of cholesterol, you need to take care of blood sugar. You need to take care of HbA1c levels. You need to take care of the all complications of diabetes like neuropathy, nephropathy, and retinopathy. And over the top of it, you'll have to take care of weight. Definitely, you'll have to take care of obesity. You'll have to take care of mood. You'll have to take care if there is an underlying depression or any other psychiatric or cognitive problem that has to be taken care of. So 360-degree diabetes care encompasses so many things. And there is an involvement of multi-speciality involvement is there. And that is something which is the need of our. We need to assess our patient. Each and every diabetic patient has to be seen from this angle. And does treatment of diabetes make a difference? Yes, it does. The prospective study of type 2 diabetes and cognitive decline in women aged 70 to 80, this is nurses health study in the US. Women with diabetes who are on oral hypoglycemic agent performs similarly to women without diabetes, and not using medication has greatest odds of poor performance. So you need to have medication, you need to have good glycemic control, and women with diabetes has 30% greater odds of poor cognitive function than those without diabetes, with a 50% increase after 15 years of diabetes. So the hypoglycemic episodes and the risk of dementia in older patients with type 2 diabetes. And this is just talking about, see the data, the hypoglycemia and the risk of incident dementia. The hypoglycemia is the most dreaded complication of diabetes. And dear friends, I've seen so many patients. There was a professor who used to visit me and at my clinic, and she came to me some 5 years back with a very high dose of insulin. She was on somewhere around about 78 or 80 units of, and she was very difficult to converse with. She was very irritable. Every point she used to have a counterpoint, and I was finding it very difficult. And the lady somehow, somewhere was not happy also. But I took my nerves. I just hold my nerves, and I treated her. I somehow I convinced her for lessening the dose of insulin, even when the sugars were not normal. And when she came back after a week from now, she was more chirpy, she was more chatty, and she was cracking jokes just because she had repeated hypoglycemia. And I took a right decision of lessening the dose of it. And somehow, somewhere, in long run, she was a very courteous and good patient. Initially, she was very irritable, hardly sitting in my waiting. She was just throwing so many tantrums. But later on, when I curbed this problem of repeated hypoglycemia, her mentation, her behavior, her cognitive functions, it improved like anything. And she was in a very good mood in the subsequent follow-ups. So this is how the hypoglycemia, and it leads to dementia, it leads to loss of memory, even the late, antrograde and retrograde, both those kind of amnesia seen with repeated hypoglycemia, and the behavioral changes is something which should be deaded off and it should be taken care of. So review glycemic targets if significant cognitive impairment, if the patient is not behaving properly, if he is very irritable, take care of hypoglycemia, because hypoglycemia unawares sets in when the repeated episodes go unnoticed. And even if you have a dysautonomia, then definitely the hypoglycemia will go on, because this palpitation, tremors, extreme hunger will not be present in those patient who is having dysautonomia. The evidence of advanced, poorly controlled cardiovascular or microvascular complications, life expectancy is less than 3 years, and end of life palliative care. So this is something which is there. Adverse effects of dementia, diagnosis and management of diabetes. See the HbA1c, this is in the past year, dementia, no dementia, see the data, and as compared to that. And when you have a good HbA1c, the chances of getting a dementia also less. And see, if there's a correlation with that cholesterol. You need to take care of the eye examination or all the three tests. So dementia reduces the likelihood that individuals with diabetes will receive recommended annual monitoring for diabetes. That is also a problem. So this is something which is there. And with that, I will end my talk. Just I want that you should be more aware about the problem of dementia and diabetes, about the problem of depression in diabetes. This is something which is very important because it's a reflection on mental health, and vice versa, the reflection of mental health on poor HbA1c control is always there. So, dear friends, from now onwards, I hope you'll pay more attention as I'm doing in my clinical practice. So this is, I'm not preaching or teaching. It is something I'm sharing what I'm seeing in my clinical practice. I hope uh, this will do justice to my presentation. Thank you. Thanks a lot.
Jaiprakash sir, please unmute yourself and share your screen, sir.
Okay. Is the screen visible now?
Yes, sir. Perfectly. Continue, sir.
So most of the topic has been already covered by Dr. Sachin sir. So we will start with the basics of mental health, how mental health is related to physical health, and why we need not to differentiate between these two health, because health is a very comprehensive concept. Health means a sense of well-being related to physical health, mental health, and social health. So we will briefly discuss about mental health related to diabetes. Uh, there was an earlier concept, mind-body dualism, that mind and body are somewhat separate, and the concept which evolved was mind-body connection. Now we know that mind and body are somehow connected. Earlier in 17th century or prior to that, autopsies were not done. No postmortems were conducted because it was a feeling that uh, there is soul which stays inside, and church forbade the conduct of autopsies. A French philosopher called René Descartes uttered his famous dictum, cogito ergo sum. By this, he somehow differentiated or dissociated mind from body. And in due course of time, autopsies were conducted and medical science advanced a lot due to those. So when Descartes uttered his famous dictum, cogito ergo sum, he separated mind from body. He did medicine a favor. But now, the idea that mind and body is separate is holding medicine back from fully exploring the interactions among mind, body, and brain. Mind, what is mind? Mind, brain is a organ of our body, and brain has many functions. Brain has functions related to thoughts, memory, emotions, perception, and which we believe to be a function of mind. So basically, mind is nothing but is a function of brain. The idea constrains our knowledge of how depression and anxiety complicate illness such as heart disease and cancer. So if we see mind-body dualism that they are separate, we will constrain our knowledge of how depression and anxiety complicate illnesses. Now we say that कई बार what we see is कि डॉक्टर के बिहेवियर से या जो एटमॉस्फेयर क्रिएट होता है उससे भी many a times patient improves. So care as well as cure, both are important. Medical treatment as well as psychological healing, both are important in um, making a person cured. Or our bodies are merely the structure which house the mind. Mind controls most of the things. Even when we see about the hormones, the main hypothalamus is a part of the brain. So hypothalamus is a controlling factor on all other hormones. So mind or brain somehow controls all functions of the body. Then depression and medical illnesses, there is interrelationships. When we see in a community, we found that prevalence of depression is roughly 2 to 5%. When we go to primary healthcare centers or primary healthcare institutes, we find that the prevalence of major depression rises to 5 to 10%. And in medically ill persons, prevalence of depression rises up to 6% to 14%. So identification and effective treatment of comorbid depression is essential. This is list of various chronic medical illnesses and the rate of prevalence of depression in those illnesses. In chronic pain, depression is as high as 35 to 50%. In myocardial infarction or heart attack, the incidence or prevalence is about 20%. In diabetes mellitus, as Sachin sir also said, various studies talk about different prevalence rate. We roughly assume it to be 25 to 30%. In Parkinson's disease, it's 30 to 50%. In terminal solid tumors, up to 25 to 38%. Cerebrovascular accidents or stroke also has a high incidence, high prevalence of depression, 27 to 35%, and similarly in epilepsy and renal disease. Then what are these links between depression, diabetes, and psychiatry? There might be two different conditions coexisting in a patient, present as co-occurring independent conditions with no apparent direct relation. That may exist. Diabetes as a risk factor for development of psychiatric disorders. If a patient has diabetes, he is more likely to suffer from diabetic distress, depression, anxiety, sexual dysfunction, and even eating disorders. Psychiatric disorders as risk factor for emergence of diabetes. If a patient is suffering from depression, then he is more likely to have diabetes. Even a patient if has bipolar disorder or schizophrenia, he is more likely to have depression. Overlapping clinical presentations of diabetes and psychiatric disorders. Then there might be some interaction of medicines or impaired treatment adherence. So we will discuss briefly about all of these factors. What happens when diabetes and psychiatric conditions co-occur? What are the implications? The common implications are impaired quality of life. The quality of life of a depressed patient deteriorates. He has poor self-care, somehow he neglects his medicine. It leads to increased cost of care, twofold or even higher than the population without co-occurring psychiatric disorders. Depression or other psychiatric disorders can lead to poor treatment adherence. He might not go for follow-ups. He might not go for admission if is indicated. It also leads to poor glycemia control. HbA1c level rises in such patients. Increased emergency room visits due to diabetic ketoacidosis because he is not taking sufficient care of himself. So the incidence of diabetic ketoacidosis rises, and this might lead to higher frequency of hospitalization, and it will further increase the cost of care. And depression along with diabetes will lead to higher rate of absenteeism from work, absenteeism from school or whatever the person is doing. Depression affects negatively the glycemic control. This is the diagram which is showing that the orange line is depressed patients and the blue line is non-depressed patients. And we can see that the HbA1c level is very high, up to 9.5, and it fluctuates more often in depressed patients. In non-depressed patients, is roughly falling between 5 to 7. Then depressive symptoms are present in 30% of people with diabetes. About 30% people with diabetes have depressive symptoms. Major depressive disorder occurs in 30% people with type 2 diabetes, which is double the rate in general population. Major comorbid depression worsens clinical outcome in type 2 diabetes. So depressive symptoms are up to extent of 30%, but when we talk about major depressive disorder is the clinical entity which has minimum duration is 2 weeks, and all criteria given in DSM-5 or ICD-11 needs to be fulfilled to call it major depressive disorders. So depressive symptoms can be up to 30%, but major depressive disorders incidence is 10%. Comorbid depression worsens clinical outcome in type 2 diabetes, and possible explanations are lower level of physical fitness and reduces medicine adherence. When we treat depression, it improves insulin sensitivity as well, and that's very wonderful because it shows how it's important to treat depression in a diabetic patient. Many diabetic patients, which I normally see, they don't go for follow-ups even to a physician or an endocrinologist. So it's a high probability that their depression goes undiagnosed and missed, and they may have higher insulin requirements due to that. So I advise all patients to have regular follow-ups, and if an endocrinologist or a physician advises that you need a psychiatric consultation or mental health professional consultation, you should always go for it. Increased index of insulin sensitivity following tricyclic antidepressants. Decreased body mass index, total bad fat mass, HbA1c, and improved self-care with bupropion. So bupropion also causes good relief. Tricyclics also cause good control. Reduced depression severity predicted HbA1c in both acute and maintenance phase with bupropion treatment. Depression is frequently undiagnosed and untreated in medical and primary care setting. Although it's highly frequent, it has negative effect of health and it's treatable. If you treat depression, the patient becomes all right within few days. And what it leads to, by missing this diagnosis of depression in medical setting, we lose an opportunity to improve quality of life of a patient. Patient might commit suicide, so we use an opportunity to decrease risk of suicide. Due to depression, hospital stay is lengthened. We use an opportunity to shorten hospital stay. And we lose an opportunity to improve treatment compliance. So if a patient of diabetes is suffering from depression, it's very important to treat depression. Otherwise, all these things might happen. Cost of care will scale up. What are the causes why we often miss depression? Go for follow-up, so we don't even see them. They might be suffering from depression. Even when they go for follow-up, most medical visits last less than 15 minutes. And there are not many issues to be addressed in this brief time. So many a time depression is missed even after consultations. Then many a times what we see in our government setup, there is overcrowding, lack of privacy. Lack of privacy in medical setting limits disclosure. Patient will not say, I'm not feeling well. Even when you ask, how are you? Most people say, I'm fine. They hide their pain. So lack of privacy in medical setting limits disclosure or elaboration of symptoms. Then lack of time and skill on part of clinician to manage emotionality. Many times the interviewer or therapist or physician is not qualified or experienced enough to handle emotionality. Many times patient starts crying within the consultation room. So we need to have a sensitive approach. If a patient, if we have asking some emotional issue, and if he is elaborating, then we need to cool him, calm him down, and explore further what are the severity of the symptoms. Then patient may not recognize depressive symptoms and may attribute them to the medical condition. Patient might feel that if I am lethargic, that might be due to diabetes. If I am fatigued, then it might be due to diabetes. Many symptoms of depression like anorexia, fatigue, weight loss, insomnia, psychomotor retardation, and diminished concentration. These are similar to medical illness. So patient as well as physician both might miss the diagnosis of depression. In context of serious medical illness, it is often difficult to differentiate normal adaptive psychological reactions. When a patient of diabetic ketoacidosis comes in emergency room, so many times we might feel that his or her depressed mood is due to adaptive psychological reaction rather than dysfunctional psychological state or overt psychiatric illness. So we might confuse it with it's like a normal response of a patient if he's suffering from any such illness. So a depressed mood or withdrawal from physical activities that is disproportionate to the physical disability increases likelihood that depression is present. So we should always look up what is the proportionate symptoms and what are disproportionate symptoms. Many times the symptoms are disproportionate. Then we were talking about diabetes distress. Diabetes distress is the patient has some distress, but it's not exactly depression. It doesn't qualify or fulfills the criteria to be a depression. So despondency and emotional turmoil, specifically related to caring for diabetes, the need for monitoring and treatment. Most people who are on insulin, they are very fed up with the insulin. Daily, they have to put 2 or 3 injections. And that's not easy for them. That causes some stigma, shame. They don't feel self-efficient in their work and social functioning. So despondency and emotional turmoil specifically related to caring for diabetes, the need for monitoring and treatment, preoccupation with complications, because many times diabetes present with complications like retinopathy, nephropathy, neuropathy, and multiple system involvement, and the effects on various relationships. Right now we are talking more about type 2 diabetes, but when we see about type 1 diabetes, it has even more psychiatric complications compared to type 2 diabetes, because if a 4-year-old kid has a blood sugar level of 450, that affects the kid also and the family also, parents also, his siblings also. So diabetic distress is related to poorer diabetic outcomes. This is brief how we evaluate diabetic distress and how we evaluate major depressive disorders. For evaluating diabetic distress, we have a diabetic distress scale that is roughly 17 items. And for major depressive disorder, that is PHQ 9, because depression has 9 criteria. So we mark all these criteria, and if out of 9, 5 criteria are present, then we call it as a major depressive disorder. So they both are in self-reporting questionnaires. And in diabetic distress, emotional burden subscale carries 5 items. Physician-related distress subscale carries 4 items. Regimen-related distress subscale carry 5 items, and diabetes-related interpersonal distress subscale carry 5 items. Similarly, major depressive disorders has symptoms like changes in vegetative symptoms like sleep and appetite, symptoms like low mood, reduced enjoyment of physical activities, psychomotor agitation or retardation. Then can be feeling of guilt. There is feeling of worthlessness, feeling of guilt. There is feeling of hopelessness. Nothing will be good at in future also. And there is a feeling of helplessness. All these feelings can be present in depressive patients. Now we'll talk about cognition. As Sachin sir already told that diabetic patient may present with dementia. So impact of glycemic control on cognition, because frequent hypoglycemic episodes may damage neurons in the brain. Even hyperglycemia damage neurons. So impact of glycemic control on cognition. In our memory clinics, we find that when we see a diabetic patient, we do MMSE, mini mental status examination, and we find that many times diabetic patient has poorer cognition and they are shifting towards dementia. So Accord Mind Memory in Diabetes sub-study of action to control cardiovascular risk in diabetes. This was a trial which included 2,977 patients. Mean age was 62 years with type 2 diabetes. 20% patients were found to have undetected cognitive impairment. They didn't knew that they are forgetful or have poor memory and poor cognitive functions, but 20% patients had undetected cognitive impairment. There was no difference in digital subtractions. This is a test for measuring cognition, DSST, and greater mean total brain volume on MRI. So when the patient of diabetes comes, we routinely screen for retinopathy, neuropathy. We get a fundus examination every year. We do tests for microalbuminuria. We screen for peripheral arterial disease or cardiovascular or cerebrovascular disease, but we often miss cognitive impairment or dementia is often undiagnosed. This is due to perceived lack of benefit of early diagnosis. If we feel what are the benefits of timely detection of this cognitive impairment? Potential benefits of timely detection includes maximized function. If a patient is able to independently do his functions, then it will lead to greater independence. Then early treatment or care can be instituted that will improve health-related quality of life. It will lead to better clinical management and that will reduce healthcare cost and care burden. Caring for a dementia patient is very difficult. And if we employ a full-time nurse for a dementia patient, that is a costly affair also. So most of the burden falls on the family. Then diagnosing psychiatric disorders among patients with diabetes. Up to 45% of cases of mental disorder and severe psychological distress go undetected among patients being treated for diabetes. Due to the factors which we have already discussed, we can use PHQ-9, hospital anxiety depression scale. We can have routine evaluations. Optimum treatment for better control. And depression, diabetes is depressiogenic. Even diabetes can lead to depression. This behave by biochemical changes, including neuroendocrine changes such as hypercortisolemia, leptin activity. It can be due to multiple factors. Among anxiety disorders, generalized anxiety disorder consistently increased risk. Diagnosing diabetes in patients suffering from psychiatric illness. Psychosis itself increased risk for diabetes, increased mortality risk, decreased medication compliance. The medications involved in development of antipsychotic, even our antipsychotics many times cause hyperglycemia. Olanzapine, clozapine, risperidone, quetiapine, many drugs lead to hyperglycemia. So that occurs due to mainly H1 receptor antagonism, antihistaminic receptor antagonism, increased plasma lipid, weight gain, leptin resistance. Insulin resistance may occur in absence of weight gain. Then first generation antipsychotics have increased risk, especially phenothiazine, but less so than second generation. Second generation antipsychotics like clozapine, olanzapine, risperidone have increased risk to cause diabetic ketoacidosis and impaired glucose tolerance. And it might also induce insulin resistance. Oral glucose tolerance test is most sensitive in detecting patients with impaired glucose homeostasis. Depression as a risk factor for onset of type 2 diabetes. This was also discussed by Sachin sir. The pooled relative risk was 1.26 using fixed effects model and 1.37. So that's a relatively higher risk. So depression is a risk factor for onset of type 2 diabetes. Even bipolar disorder and schizophrenia are also risk factor for onset of type 2 diabetes. Then these are the potential mediators of cognitive impairment. It can be due to genetic predisposition, cerebral microvascular disease, dyslipidemia, HPA axis dysregulation, acute hyperglycemia. So there are multiple factors which can lead to cognitive impairment in a patient with type 2 diabetes mellitus. These are mechanisms that may link diabetes and dementia. It can be due to macrovascular factors like brain infarcts. It can be due to microvascular factors like ischemia or functional hyperanemia or hyperglycemia due to advanced protein glycation, mitochondrial dysfunction, oxidative stress. These all can be linked to causing dementia. Insulin resistance also causes dementia. Amyloid deposition, inflammation, neurotransmitter imbalance, all this can lead to so macrovascular brain infarcts lead to vascular dementia, microvascular or hypoglycemia most likely causes mixed dementia, and insulin resistance leads to Alzheimer's type of dementia. And dementia is a disorder which we don't have much treatment of dementia. So if a patient is suffering from dementia, we give drugs just to delay the progression of the disease. We don't have exact cure for dementia. So caregiver burden increases to a significant extent in dementia, and it also increases the cost of care. So there is a potential role of insulin in pathogenesis of dementia. Then cognitive impairment affects management of diabetes and treatment-related complications. So less involvement of diabetes on diabetes self-care and monitoring. It leads to increased likelihood of severe hypoglycemia. Then it will increase risk of major cardiovascular events. Then it will increase risk of injurious falls. So cognitive impairment hampers the quality of life. It leads to many complications. It leads to many injuries and falls. Efficient screening tools and to establish whether early detection can improve long-term outcomes. So we have found out that screening tools are important, and if timely detection is made of cognitive impairment, then it will definitely improve long-term treatment outcomes. This is a screening instrument, mini COG, a quick screen for significant cognitive impairment in people with diabetes. It has 3 items related to recall. So, in a GP study of older people, mini COG had sensitivity of 86%, specificity of 91%, and positive predictive value of 54%. And it was independent of educational status or cultural or language. So it was a good tool to evaluate cognitive impairment in patients of dementia. So if score is 0, patient is demented. If score is 1 to 2, and if CDT is normal, then it's non-demented, and CDT abnormal, then it's demented. And if the score is 3, if he is able to recall all 3 things, then the patient is not demented. Then diabetes also leads to erectile dysfunction. Diabetes is associated very strongly with sexual problems in both men and women. And if a young patient of reproductive age group is having erectile dysfunction or sexual dysfunction, then the life becomes difficult. Diabetes has numerous end organ effects, macrovascular, microvascular, neurological. So they all exert a substantial psychological toll which may predispose diabetic people to sexual problems. Men with diabetes tend to develop erectile dysfunction 10 to 15 years earlier than men without diabetes. As men with diabetes age, erectile dysfunction becomes even more common. So we need to treat erectile dysfunction also in such patients. Other psychiatric associations which are included, which occur with diabetes includes mood disorders, anxiety disorders, feeding and eating disorders. Eating disorders in a patient with diabetes, the patient is suffering from diabetes and he has a binge eating disorder or bulimia nervosa, then the management becomes quite difficult. Then in cases of schizophrenia and other psychotic disorders where patients don't have insight, the management of medical conditions like diabetes becomes difficult. Then degree of risk of diabetes with antipsychotic drugs, we have discussed about it. There is high incidence with clozapine and olanzapine, then moderate with quercetin, risperidone, and phenothiazide. Like haloperidol. Risk of diabetes is minimal with aripiprazole, amisulpride, and other antipsychotics. Then psychotropic induced metabolic syndromes can occur. Syndrome antipsychotics with tricyclic antidepressant, valproic acid, lithium are associated with metabolic syndrome, increased risk for diabetic ketoacidosis. Weight gain is a significant. You can see with clozapine 6 to 12 kg of weight gain in first year, quercetin 2 to 4 kg of weight gain, and risperidone 2 to 3 kg of weight gain. Aripiprazole and ziprasidone are weight neutral drugs. Then these are some drug interactions. Fluoxetine and fluoxamine inhibition, cytochrome P3A4. It can affect pioglitazone, repaglinide, netaglinide metabolism of these drugs. And through cytochrome P2C9, it can affect metabolism of glimepiride. So choosing an antidepressant, special considerations, power inhibitors, hypoglycemia can occur, orthostasis can occur. When we give tricyclic antidepressants like imipramine or amitriptyline, weight gain, increased glucose and cardiac conduction delay can occur. SSRIs are completely safer. Escitalopram, paroxetine, sertraline are completely safer drugs. They improve glucose control, reduce insulin requirements among type 2 diabetes. So, hit molecules for physicians, cardiologists, nephrologists, and is SSRIs. SSRIs has minimal effect on heart and it doesn't affect glucose metabolism as well. So I conclude with this quote from Sir William Osler. It is much more important to know what sort of a patient has a disease than what sort of disease the patient has. every patient may have different personality, and depending on his personality or psychological makeup, presentation of disease may vary. For a person with depression, even moderate depression can be presented as severe depression, and it might lead to many problems. If psychological, we need to take care of the psychological well-being of a patient along with taking care of his physical physical needs. Thank you.
So there are some questions from attendees. Can I read
Any
it?
query?
Hello.
Hello.
There is any query?
Sir, there are some questions from attendees. Can I read
Yes,
that?
sure, sure.
Okay. Sir, first question from Dr. Satish Kumar from Uttar Pradesh. As a diabetologist, what are the steps to diagnose depression if I suspect depression in diabetic patient?
See, there are so many things. If a patient is coming to you for the sake of diabetes control, then you need to see how the patient is behaving. Apart from that, the mood part, the facial appearance, the glycemic control, and the way the patient responds to your questions. There are so many things. And majority of the times, as a physician, as a diabetologist, there are good number of patients who say that they are not getting proper sleep, they are restless. For every point, they will raise a counterpoint. So, see, these are the subtle ways of a physician to diagnose a case of depression. So when we get full-blown cases, definitely they are to be dealt by psychiatrist only. So this is the way we diagnose depression in our clinical practice. The kind of hopelessness.
I may add something.
I think Dr. JP can throw more light in it.
Yeah, first of all, I think we need to be sensitive towards the mental health needs of the patient. We need to ask how is your mood. सबसे important सवाल यही है कि आपका मन कैसा रहता है, आपको नींद कैसी आती है, आपको तनाव किस बात का रहता है. Then we need to evaluate what is he suffering from anhedonia, whether the things in which he used to have pleasure in past is now like he doesn't have any feeling of pleasure. Is there any feeling of worthlessness, hopelessness, and helplessness? If there is suicidal ideation, then definitely the patient should be referred to a psychiatrist. If depression is mild to moderate, physician should treat him with SSRI. Initial dose can be given, then dose can be up titrated at roughly 4 to 8 weeks. And patient should be called for regular follow-up and evaluated regularly for his severity of depression. Any other
Okay.
question?
Next question from Dr. Harish Singh from Chhattisgarh. Whether strict glycemic control as recommended to prevent micro and macrovascular complications, similar helps in maintaining mental health also?
Yes, definitely. If we have good control of diabetes, it will help in depressive symptoms as well. But if a patient is not just improving on those hypoglycemic agents, then we might also need to add antidepressant like paroxetine, fluoxetine, or escitalopram to improve depressive symptoms.
Next question from Dr. Atulya Saurabh from Madhya Pradesh. What range of HbA1c do you recommended in senior above 70 years with dementia and without dementia?
So the recommendation of HbA1c is definitely we should follow the patient-centered approach in diabetes. If you're dealing with an elderly patient, and definitely with or without dementia, in either of the situation, we will not go very tight with respect to HbA1c control. It will not be, definitely it will not be 7, it will be somewhere around about 7.5. And in some cases, if someone is having full-blown dementia and the chances of overlooking the hypoglycemic episodes, then definitely I will keep it somewhere around about 7.5 to 8 will also do. But in both the settings, if we are dealing with elderly population, it should not be more than 8%.
Okay, so next question from Dr. Rahul Talati. I have a female diabetic patient controlled on Voglibos metformin combination, age 58, but she shows sometimes symptoms of anxiety. Earlier, she had taken treatment of anxiety and depression.
I think Dr. JP has to answer this.
Yes, sir. Can you repeat the question, please?
Yes, sir. I have a female diabetic patient controlled on Voglibos metformin combination, age 58, but she shows sometimes symptom of anxiety. Earlier, she had taken treatment of anxiety and depression.
You need to see if she is presently on any medication. If she is on medication, then her doses needs to be titrated according to her severity of the illness. And if she has anxiety symptoms, daytime anxiety also, then considering low dose of benzodiazepines like clonazepam will be worth considering.
Okay, so that was the last question. Rest are the greetings from the attendees.
Okay.
Okay, sir. So shall we wait or conclude the session?
I think we should conclude it.
Yes.
Thank you, Lupin.
Sir, thank you. Sir, really, this was a great session and very interactive session. And I'm sure that all clinicians will be getting this benefit about this session. Thank you, sir. Thank you.
Thanks a lot.
Thank you, sir.
Thank you.
Thank you. So I'm ending the meeting now. Thank you.
Thank you.